Great. Thanks, ladies and gentlemen. Well, what, 320 pages of new stuff that have come out on lipids after 10 years has really sort of knocked everybody out. But I don't, to me, it's not such a huge change, and we'll talk about it more. What I first wanted to talk about, because this is sort of a preamble to talking about that later, because they really focus on statin use and nothing else. And I think that's important in terms of the scientific look at what we can expect absolutely correctly scientifically from lipid changes. But there are other sub-analyses and stuff because we deal with patients who are very complicated and different. And so I want to go through and show you what those other studies show, which they sort of rejected so that you can know sort of what to do. So let's just go through them quickly. So what we're going to talk about is diabetic dyslipidemia, and with triglycerides greater than 200, and then these HDLs less than 40 and 50 in men and women, with generally small LDL particles, where the standard lipid LDL will underestimate your LDL in terms of the particle number. So you always can look at those tiny little LDLs in people with diabetes. That's not where they really are in terms of the damage from LDL from these many, many more smaller LDL particles that get into the subendothelial space and do cause plaques. So let's go ahead. One of the things I want to introduce to you, which has really helped me enormously, is the concept of the non-HDL cholesterol. So what the total in a fasting state is the LDL, the lousy one, plus the healthy HDL, plus the cholesterol associated with the VLDL or VLDL remnants, which are where all the triglycerides are. Therefore, the total cholesterol is the combination of all these things. So these are proatherogenic, the LDL and the VLDL cholesterol, whereas these are usually antiatherogenic. And this is often used when the triglycerides do exceed the 200. So non-HDL is just simply total minus HDL, so it's LDL and VLDL cholesterol. Since we want triglycerides less than 150, and since VLDL cholesterol, since triglycerides want less than 150, you divide by 5. We want the VLDL cholesterol be no more than 30, so if you then look at the non-HDL goal, it's always 30 milligrams per deciliter greater than LDL. So this is looking at non-HDL through an enormous amount of trials, as you can see here. Jennifer Robinson, who was one of the co-chairmen of the new guidelines, was part of this, and I figured that non-HDL would come out in this thing, but it didn't. And I think it's because simply nobody is focused in trials on that particular number. But this is where when we look at coronary heart disease risk reduction, relative risk reduction here, and non-HDL reduction here, it's a one-to-one reduction. So that if you get a 20% decrease in non-HDL here, then you're going to get a 20% decrease relative risk reduction. So you can think of that as a one-to-one. And what this does, it doesn't just consider an LDL, it considers triglycerides and HDL in one number. When I show it to people and call it non-healthy cholesterol, and this is where we want you, they immediately understand and see the number and can see where they're trying to go looking at all of these things. So does it predict coronary heart disease events better than LDL in statin-treated patients? So here we're using statin trials, and the quartile 4 versus 1 for major cardiovascular events, when you're looking at levels of ApoB, non-HDL, or LDL, this is higher, and it's actually higher than one of the particle numbers, which would be ApoB, in this particular study. And this is 8 statin trials. So it is not a worse measure. In fact, in most all studies, it's a better measure than LDL cholesterol. In this same study, they looked to ask the risk of a major cardiovascular event by LDL and non-HDL categories. So at the bottom, we want LDL less than 100, non-HDL less than 130. That's where you get it right here. But if you have LDL less than 100, but the non-HDL is over 130, over that goal, then the relative risk is here. And it's as high as people whose both LDL and non-HDL are not at goal. So because of that, what we try to do, this is where the LDL is higher than 100, but the non-HDL is at goal. And you get a much better relative risk reduction using non-HDL as opposed simply to looking at LDL. So this is a little bit of a difference. As you know, Quest actually puts it on the documents now. Other places don't, so you have to be able to subtract out very well yourself, total minus HDL. So if you were born in 1950 or something where you did it all on the blackboard, it's very easy. But if you did it, you know, more recent, it's going to have to get out the machines. But I think it's important to begin trying to do that. I found it extraordinarily helpful for patients the more I've tried to use it. So first of all, how do we lower the triglycerides? And for me, lowering triglycerides is the first step because the LDL will change. As the triglycerides come down, LDL cholesterols generally rise. And so rather than starting exactly first time with a statin, I tend to try to do lifestyle changes to move the triglycerides around. And these are the 4 things you've got to go over with each patient. First of all, if those are overweight or obese, you've got to try for a 10% weight loss. And you got to just calculate it out and not make them think they can do better than that. Then this is what you go through in the diet. When you go through breakfast, lunch, and dinner, you ask them about fruit juices. Many people love fruit juices. The other thing are any sort of sodas. They hate the sugar substitute, sodas, so they take the regular sodas. There was a guy just this morning who had that, and his triglycerides were 500, and they can go up to 1,000. I said, you've got to get rid of those things. And if they do, you're going to see that that triglycerides will just simply go way down. If people are drinking a half a bottle of wine per day, they can't do that. Okay, I say 1 or 2 standard drinks per day is okay. Some lipidologists say absolutely none, but that's fairly difficult. But you don't want gin with regular tonic with all that sugar, and you don't want vodka and orange juice. Okay, so you've got to get rid of the simple carbohydrates in those. And second of all, increasing physical activity increases the lipoprotein lipase, which chomps up the triglycerides as they go into the muscle and the fat tissue. So those 4 things are always the thing. And when you see a patient, you've got to figure out which of these things can I harp on. And if they've done them all, then you're stuck. There's nothing more you can do. But these are much more powerful than fibric acids or niacin or fish oils, and they will way outdo it. And if they don't do these things, those drugs don't work very well. So you have to do both things. So these are the drugs we generally use, okay, that have not been touted very highly this week. But I wanted to look at the statins on how much they lower triglycerides, because the statins will lower triglycerides, all of them. But if you look in these pink numbers, as we get to more and more powerful statins, you have more and more triglyceride lowering percentages. So example, if you're up here at the top with Crestor or Rosuvastatin, you're up around 25%, and here you're up at atorvastatin from 20 and up, you're up at about 25%. So you can figure with lifestyle and with statins, you can lower triglycerides quite substantially, and people under 400 for triglycerides, often that's all you need to manage. You will not need to use anything else to help those. If you go back to simvastatin and even to the weaker statins, you see they have much lower triglyceride lowering effect, and therefore you want to go to the more powerful ones. So this is a cord lipid. Does adding a fibric acid to a statin make any difference? And so these were all type 2 diabetes with fairly good control of A1Cs. They had already been on simvastatin, so they had LDLs less than 100. Phenotype rate 160 versus placebo, and there were a large number of things they included in the outcome. The thing I want you to look at this is these values and the differential changes. As far as I'm concerned, these drugs have been shown in individual studies to reduce risk. And the question is, why wouldn't they, when you add them to a statin, do the same thing? So when you know something should be good and it's not good, you have to go back and look at the study design. And the studies may have been designed well, but not achieved what would have been big enough differentials to make a difference. And that's my interpretation of these trials in general. So if we look at the LDL, and here on in the dark underlined are the comparative values at the end of the trial on the drugs. So here's statin and fenofibrate, and statin and placebo. No difference in LDL. The HDL, there was essentially a 1/2 milligram per deciliter difference. If you look at triglycerides, yes, the fenofibrate brought those down, but not hugely. So what you're dealing with in the non-HDL differential is 110 versus 114. No one would expect any trial result positivity out of that tiny, tiny differential. So the other thing I want to mention about fenofibrate is you have to know that it raises creatinines. And so there are people who you might use that on, and the creatinine goes up, they get to insurance, and they're refused. So then you have to bring them back, take it off, and let the creatinine fall. It's a reversible thing, but just remember that with that particular drug if you do wish to use it. And this was a totally negative trial in all these different parameters. Nothing better happened. So what they did was then the sub-analyses. And these are specified, pre-specified subgroup analyses. The only one that is different, for which the additions seem to work, is this one here. Not with just HDL, which was low, which is this one, and they're all the same. Not this one where the triglyceride differentials, this being triglycerides greater than 200. But in this group right here, triglycerides were greater than 200, and HDL was 34 or less, or under 35. So in this particular group, you're getting, if you look at the relative risk down here, is 0.7. I mean, it's a major change. And the actual percentage of the absolute reduction here is 17.3 versus 10%. So 7 into 100 is what, 13 or 14? So 1 in 13 to 14 people with this sort of pattern by this sub-analysis should have one of those events reduced. Now, what the new analysis did was say, look, this is a sub-analysis. Therefore, because we're doing this for absolute certainty in reanalyzing these things, we cannot include this. This does not justify whatsoever in giving any fenofibrate to a person who's on a statin. Therefore, we do not recommend it. We only push statins. And that's been the general theme one of the general themes of that. And I think each of you have to make up your own decisions about these things. I mean, it is difficult, but they're dealing with, there are a group of people who just hate all these other drugs, think the pharmaceuticals are making a big difference and pushing drugs that are not proven. So this was an effort to get absolute solid evidence that no one, the new guidelines could contend with. So what about niacin? Let's just go through the same thing. This is what niacin at different doses will do, 500,000, 1,500. Look at the triglyceride reductions. It's 5, 14, 21, 32. It's 7 or 8 percentage points as you go up in the dose here to 2,000. So it's about 32% reductions with niacin. If you look at the LDL, and you're seeing that going down here, it's by 2,000 you're down. It's not very powerful. 16% reduction. It's not huge, but it is something. The main thing is the rise in HDL, which you're seeing here, and it goes up and it stays up like that. So when the Coronary Drug Project, which was reported in 1975, okay, this was 10 years prior to the onset of the statins, which were in the mid-'80s and has been around 26 years now. This was one of the great trials that I remember because, in fact, with niacin, you can make a huge difference. There was a 14% reduction in MI and death. Non-fatal MI was a 27% reduction, and strokes even went down 26%. If after 15 years in a long-term follow-up, they even got mortality benefits. You never can forget this trial when you ask whether adding it makes a difference. We know by itself it makes a difference. And the question is then, why, when you're giving it with a statin, don't you get any benefit? So let's go over some of the trials that have been done just to ask those questions. Arbiter 6 HALT was a small study. It was a carotid IMT study, 363 people on high-dose Zocor or Lipitor, so they had this low LDL of less than 100. And the women and men had slightly lower HDLs. They're at the bottom 50th percentile, 50 percentiles. 14-month carotid IMT, and they randomized to Zetia or Niaspan 2000. There was no placebo group in this. So let's just look now at the baseline and at the on-trial 14-month differences. And when you're looking here, what happened to the LDL? Well, there's a 5 milligram per deciliter difference here. It's a little bit better with the Zetia, since it's a 20% reduction, and this is 15% when you use the niacin. The HDL was major difference. You see that 10-point difference? The non-HDL was not different at all in this study. You would expect nothing to happen based on my use of non-HDL. But the other thing that's happening is you're getting this 10-point major change in HDL. So what happened into the IMT? It stayed the same. It didn't get larger or smaller in terms of use of Zetia, but adding niacin, you did get this reduction in the IMT thickness. And lo and behold, it's unbelievable. When you look at all these events up here, they did get a p-value of 0.047 decrease on those with niacin versus ezetimibe. And one of the things that Taylor was saying, well, the Zetia is toxic, okay? And that's what caused this. It's not, the change, the benefits you get from the niacin. The higher rate in the Zetia group is from a toxic thing. But there's the ongoing study of Zetia, statin versus a statin, and it's still going on. There's no futility yet. It's taking a long time, for this to be shown. But until we get that study, we're not going to actually know what Zetia will do. There is a study, though, in American Indians out west, in which they targeted and said, this group will get you to 100, and this group will get you to 70, and we don't care how you do it, but you're nurse practitioners, you're going to do it, and they did it. So for 3 years, they had 70 and they had 100. And they looked at IMTs, and there was a significant reduction in those people who were on the Zetia, who had the 70 versus 100. I mean, the new guidelines say there are no targeted trials for LDL, and this is about the only one there is, in which they use whatever medicines, but they just targeted the numbers. So they did have the reduction in IMT, and then they asked, look, who got there by statins? Well, this group got there only by statins. This group used Zetia. Is there a differential? If it's not working, basically the Zetia, you're not going to get the same differential. But the differential in IMT was the same whether you're using pure statins or statin plus Zetia. At least that, for me, reconfirm the LDL hypothesis that no matter how you get LDL down, you're going to make a difference. And so using that and using the guideline approach, which is the approach we've been using for 10 years, you would use these combinations. What the new group is saying is basically you don't have outcome trials where you have targeted areas, and therefore you can't use all the data, much of the data we're talking about. Okay, let's just keep on. So the inclusions is those with CHD, HDL less than 50, and LDL less than 100. That HDL greater than 10, the rise, added to statin-reduced events in Arbutin. AIM high was another important one, in which niacin ER2000 versus placebo niacin. It's the simvastatin with the niacin added. Now, this is a negative study, as you know, too, and has framed much of the non-use of niacin at this point. But what happened was there was a differential. Zetia was Zetia was allowed to be given to maintain the LDL in this group. And so when you're not on niacin, 22% in the placebo group are on Zetia, whereas 10% in the niacin group are on it. So you're going to have less of a differential in LDL based on the fact that they were trying to keep people in this low range and therefore used another medicine to do it in the placebo group. In addition, in the niacin group, 200 of niacin extended release to maintain the blind was enough to lower, to get some of the niacin changes and therefore make the niacin placebo changes less. And these were the endpoints. And many of these people had either metabolic syndrome or diabetes. Many people had been on statin therapy for years and years. So as I think, when you get out further and further and people are surviving in statin therapy, you're going to have trouble adding something else at that point to make even another huge difference. And that may, again, many of these people had been on, for over 1 year, and many people on for 5 years. So let's look at just the differences here that you see in the aim high values. So the HDL went up 5 milligrams per deciliter, and this is the niacin statin versus statin placebo. What happened to the triglycerides? They went down as expected. The LDL was about the same, a little bit less here. The non-HDL, what was the difference? It was 9 milligrams per deciliter. Again, if you don't get any big changes in the non-HDL, you need 30 to 40 milligrams per deciliter changes to make sure you're going to get some measurable event within a 5-year period. And so I think, to me, this is one of the reasons. Of course, it was absolutely, this is not a power issue. When you have overlying lines, you can take 1,000, 1,500 more people, and you're never going to separate those lines. It's only if it's a small separation, and with more people, that will be significant, that small separation. But they're parallel nihilistic lines. So HPS2 Thrive was the heart protection study in which they had done it using simvastatin, and now they're taking 26,000 patients in the 4 original Scandinavian countries, and the total cholesterol was 135 on simvastatin. And then they were randomized to keep on this, plus or minus Zetia, and then simply to add the niacin versus placebo and go for a 4-year follow-up. So these were the male, female, the ages, the people with diabetes here, and a lot had already had disease. And these were the differential lipid values at 4 years. And let's take a look. The triglycerides were less with the niacin. The HDL was 6 milligrams per deciliter greater. The LDL was minus 10. So the non-HDL difference was minus 17. You're not simply getting, with these trials, apparently the differential that you might get in an individual patient. And that's where your interpretation of your individual patient's result, I think, come to be so very important. This just shows that none of these events, the risk ratio was 0.96. It was a negative trial. When they looked at the LDL, sub-analyses by baseline lipids, there was no difference depending upon where you started with an HDL, but where you started with an LDL made a difference. With decreasing relative risk and more improvement, the higher the baseline LDL was. So let's take a look at this woman and see what you want to do with her. She's 51. She has no cardiovascular disease, but her father had a stroke and bypass at age 78, fairly late. Grandparents, 70s and 80s. She had a coronary calcium score, which is helping me more and more determine risk on people, I can tell you. I can use, all I can do, risk factors, but you always have these sort of clouds that you're not quite sure of what's going on. So I got a coronary calcium score, which was 148, intermediate risk. But she was at the 99th percentile for a 51-year-old lady. 51-year-old ladies, their scores on average are 0. It's not until postmenopausally they start rising at all, on average. So she was quite high. Even though the number, 148, is not of any immediate risk, we're talking about someone at 51 wanting to get to 80, 90. And so these were her values already on these drugs when she had these values, 234, 24, 102. I think the new guidelines would say, look, just focus on the atorvastatin 80 and just keep that going. But to me, this is, the non-HDL is 149. We're trying, we know that plaque formation stops at around the LDL of 80. These are from intravascular studies from years ago. And then if you want to start shrinking them, then you got to get down into the 60s for the LDL. So in her case, let's just say that we wanted to stop the plaque. We need to get her non-HDL down to around 110, 80 plus 30 would be one. And she's up at 149. So what are you going to do? Would you start statin or would you not start statin? How many would in this case? How many wouldn't? How many would start a statin to just see what happened? Not many. Okay, well, I did. So I put her on Niaspan 1,000 to see what would happen. And you're seeing these enormous changes. This doesn't happen often, and that's why I use these patients. But you will find this. Her triglycerides fell to 65, her HDL doubled, her LDL went to 75, and her non-HDL fell 60 points. Now, no one can tell me that in a study that had this sort of thing, you wouldn't get a differential. In a 51-year-old lady looking for the rest of her life with parents who in their 60s and 70s started getting events. And so that's what I do with people who may now be on niacin. I'll say, look, I don't know if you need to be on niacin, but I'm going to start pulling you away, and then we'll see what you are off of it. And if there is no differential, you'll stay off of it. But if we see that you go back to where you used to be, and we get these differences in non-HDL of 30 to 40, then we're not going to take you off of it. So this is what my sort of suggestions. In a person with a history of ischemic cardiovascular disease, with LDL less than 80, triglycerides less than 200, but low HDL, a non-HDL less than 115, no evidence to add ER niacin, no matter where this HDL is, because their non-HDL is already down at a very low level. But in patients already on niacin and a statin, if the non-HDL change with the added niacin, you can go back and see it was greater than 30 to 40 milligrams per deciliter, or if the HDL increases were greater than 10, I would be personally reluctant to stop it. Okay, thank you.